Hi everybody, I would like to introduce our Ultrasound of the Month series. This is the Ultrasound of the Month for July 2013. I'd also like to introduce our Critical Care Ultrasound group, which emanates from the Surgical Translational Research Center, the STAR Center. That's myself and Raghu Sethala, an emergency medicine doctor and ICU doctor, Dirk Vralman and George Fennell, both well-known anesthesiologists and intensivists at the Brigham. We have no disclosures. Today, you are an ICU doctor. You're waiting for your patient to arrive from an outside hospital. This patient had orthopedic surgery at the outside hospital and had complications. First, a vent-associated pneumonia, then a limited course of postoperative atrial fibrillation for which the patient was started on full-dose heparin, but then developed a spontaneous retroperitoneal bleed which required massive transfusion, from which the patient was just stabilized today, a few hours ago. Now the abdomen is very tense, the bladder pressures are high, and the patient is being transferred from the outside hospital to your ICU for further management. Immediately upon arrival, you are surprised the patient is hypotensive but has warm extremities. He's on norepinephrine at 40 micrograms per minute. Your presumptive diagnosis is hypovolemic shock due to resumed retroperitoneal bleeding, perhaps also a contributing abdominal compartment syndrome due to massive resuscitation, but you're not sure. You order stat emergency blood products, and while waiting and resuscitating with fluids, you perform a quick bedside cardiac ultrasound. He has emphysema, so the parasternal and apical views are not satisfactory. However, the subcostal view is good. At the left, we see a mannequin with the number 1 position, that's the subcostal view. Number 3, parasternal view. Number 2, apical view. In this patient, we are only able to achieve the subcostal view. At the bottom, we see the expected schematic of the subcostal 4-chamber view. And on the right, we see the heart through the left liver lobe. At the top, we see the right ventricle beating. Below it, the left ventricle, the tricuspid valve, the mitral valve, the right atrium, the left atrium. The hyperechogenic line is the pericardium. We see that the left ventricle is filling well during diastole and is emptying very well during systole. The RV is well filled and seems to be reasonably contractile. Since we were not able to obtain a parasternal short axis view, we simply rotate the probe in the subcostal position to achieve a similar view, a short axis view in the subcostal position. In here at the right, we see a basal short axis view, including the left ventricle, that's the round donut, which is contracting quite well and filling during diastole and emptying quite well during systole. Above it, we see the right ventricle, likewise with good filling and reasonable contractile property. Our last view, when we turn the probe, we get a sagittal view through the left liver lobe, as indicated in the schematic on the left side. We see the IVC entering the RA. That's the IVC entering the right atrium. We see that, based on the scale on the right, the IVC is quite well filled, 2 centimeters or more. There is not much respiratory variability at all. At no point does the IVC collapse. So ultrasound has helped us narrow our differential diagnosis. Hypovolemic shock is unlikely now because of good filling of the IVC, the right ventricle and the left ventricle, and the lack of respiratory variability in IVC diameter. Abdominal compartment syndrome is also unlikely to be a significant contributor because the IVC is not compressed. On the other hand, distributive shock is more likely because the heart is hyperdynamic with excellent systolical, suggestive of a low SVR. This matches the physical exam with warm extremities, i.e. vasoplegia. Distributive shock could be due to sepsis. This would be severe septic shock, or due to SIRS, systemic inflammatory reaction. What is the further course? You presume severe septic shock due to vent-associated pneumonia. You add vasopressin, you empirically broaden the antibiotic coverage with new antibiotics, you start stress dose steroids, and you institute lung protective ventilation. You also send back the emergency release blood products and wait for cross-matched units if needed later. This way you avoid unnecessary transfusions, certainly with emergency release blood, and therefore you reduce the risk of transfusion-related acute lung injury. In summary, ultrasound was very useful to make real-time decisions, and it changed your differential diagnosis. It helped you avoid transfusion of emergency release blood. Thanks for listening. This concludes this month's Ultrasound of the Month. Stay tuned for our surprise ultrasound for the month of August. See you later.